right, welcome to everyone to the Quello Center Speaker Series. I'm Keith Hampton, Interim Director here at the Quello Center. And so I'll welcome you today, which I think is our second talk of the new year for this semester. And so we're privileged today to be joined by Jessica Ancker. And so I'll just remind everyone that our presentations are recorded. And the way that we do that is that the recording has already begun, but we will stop that recording in time for questions so that everyone can feel free to speak freely. We also welcome everyone and encourage everyone to turn on their videos to give our presenter a sense of presence today. And with that, I'll turn it over to Celeste, who will do the introductions.
All right, hi everyone. So Dr. Jessica Ancker joins us today from the Vanderbilt University Medical Center, where she is a professor of biomedical informatics and health policy. She was the founding director of the health informatics graduate programs at Cornell Medical College. Her research has been published in leading health informatics journals, including the Journal of the American Medical Informatics Association, where she is currently an associate editor. But before all of that, her first career was in journalism. Please join me in welcoming Dr. Ancker as our Quello Center speaker, and I will now turn over the virtual mic to her.
Great. Thanks so much for inviting me. I'm really pleased to meet you, and I've also taken the opportunity to learn a little bit more about the Quello Center. It looks like you are all doing fantastic, interesting research, so I really look forward to this conversation. I'm going to be talking about my work in evaluating telemedicine during the COVID pandemic. I'll just start by saying that I'd welcome, if you've got clarification questions about the methods or anything while I'm talking, please feel free to message or ask, and then maybe we'll postpone more substantive discussions till the end of my talk. And with that, I will I'm going to share my screen. And give me the thumbs up when you can see the screen. Okay, great. Yep, okay, good. So this is a series of interrelated projects about the telehealth explosion that we saw at the beginning of the COVID pandemic. And to start with, I thought I would just go back a little bit in history because it's not that long ago, but it's sort of easy to forget what the details were. So I'm going to say, as we recall, the first COVID cases were identified in Wuhan in China in probably December of 2019. By January 23rd of 2020, Wuhan had shut down its open air markets as under the assumption that that's where the spread was happening. By February, the CDC had actually issued the name. We weren't even calling it COVID yet. We were calling it like the Wuhan coronavirus. And so just to recollect that that's where that name came from. By March, the WHO had declared an international pandemic. Shortly afterwards, the White House declared a public health emergency in the United States. And of particular relevance to my talk, Medicare expanded its coverage of telemedicine also in March of 2020. By April, we had 19,000 deaths, and they were predicting multiple millions of deaths. And also, at this point, I was still in New York City, and New York City was the epicenter there for a while. As you might recall, they were running out of burial space. This picture in the lower left-hand corner is the mass grave on Hart Island, which is very upsetting. And it felt very out of control. We did not, as you might recall, we had no reliable really testing for COVID. It wasn't clear yet if we're supposed to be wearing masks or not because we were getting contradictory guidance. There were potentially no masks to be gotten. And treatment was very unclear of how to treat this. And, by the end of April, we were learning what an exponential curve looked like in terms of both cases and deaths. So just to bring us all back to those very scary and upsetting months in the beginning of 2020. So this was through April. By May, PCORI, that's the Patient-Centered Outcomes Research Institute, had jumped on this and recognized that this is something that we needed to be studying in real time. And they issued this targeted proposal, request for proposals about COVID-19. It was fairly broad, but it was a very rapid turnaround. I hope I can hear like virtual groans coming from over we wrote this grant in 3 weeks. Somehow we were able to pull together a collaboration across 4 different medical centers in 3 different states, who were already doing some collaborations through PCORI, through the Patient Centered Outcomes Research Network. And we were awarded this grant on comparing telehealth and in-person care for patients with chronic conditions. This is a very potentially vulnerable patient group. And, you know, we could certainly imagine that they could benefit tremendously from telehealth, from not having to travel to their doctor's offices, particularly at this point when doctors were closing their offices for infection control reasons. But I don't have to tell this audience that we also have, you know, major disparities in availability of broadband, availability of digital devices. We have race-based disparities, we have income-based disparities. The urban-rural disparity is particularly notable for broadband. So we have the potential for this new care modality that could help, but could also exacerbate the existing disparities that we see in US healthcare. So what we proposed to PCORI was to study this qualitatively and quantitatively. We proposed some qualitative work just to find out what was going on with telemedicine and how it was being experienced by different patients and different providers. And then in AIM 2, we proposed quantitative assessments using Medicare claims to determine whether telehealth was actually as effective as in-person care or not. So I'm going to give you a little bit of a preview, which is that we've largely finished all the qualitative work. Much of this has been published. Some of the quantitative work is not quite completed yet, so I'll be sharing preliminary results, which if you have additional suggestions for additional analyses, actually now is the time to tell me, because we can still do them. Okay, so we began with a survey, basically. How did we learn about the telemedicine explosion? We decided that our first step would be to survey primary care practices. And we identified 100 primary care practices across the different medical centers that were collaborating with this in this consortium in 3 different states. And we developed a questionnaire based on this health information technology model that we'd previously published in JAMIA. The gist of it is that we cannot expect a new technology to have any impact on healthcare quality unless we can ensure that it is well fit to the organization, that the users are trained on how to use it, that it is highly usable, and that it actually supports the kind of care processes that we think are related to healthcare quality. So we were able to reach these primary care leaders. These were anybody who'd been involved in the telemedicine rollout. So they were, some of them were medical directors, and some of them were more like informatics implementers. The first thing that we found from this was that there was very rapid change in the early months of 2020 to get telemedicine up and running. A small number of practices already, or medical centers, had some sort of telemedicine in place, but it was, I'm going to say it was mostly a boutique offering. It was offered for things like self-pay urgent care that you know, busy executives might be able to phone in and get an urgent care consultation by telehealth. But it was not being used for primary care. It was not being covered by insurance prior to 2020. So most places didn't really have much of anything up and running. Over these first few months of 2020, it became clear that if the doctor's offices were closed to in-person care, they had to offer something, and they scrambled. So we saw really rapid evolution. We saw people starting with audio-only visits and transitioning to video visits. They tried a number of different telemedicine platforms before they chose one that actually worked for them. Almost all of them started integrating the telemedicine into their electronic patient portal. That was not usually how they were doing it at the beginning of 2020. A big headache was interpreting services. In the first few months, there were these, I'm going to say, horror stories about having a video visit with a patient and then having a telephone with the interpreter also going at the same time. Usually by mid-2020, they'd worked that out and the interpreter was able to actually participate in the video visit. Training opportunities for patients, orientation for providers as well. We saw anecdotal reports that technology-related interruptions were going down. And again, from the leadership perspective, they were saying that there was increased access to telehealth. I'm going to hold off on whether I believe them or not, but that's what they were telling us, which is kind of nice. And the insurance changes meant that it could be made available to a wider range of people. So this was our first sort of baseline of what was going on across at least these 3 states. And we then did a much deeper dive in purely qualitative research on what was it actually like to do telemedicine visits during this time. We were focused on patients with chronic conditions who were in primary care, not specialty care. We weren't really looking at mental health care, which I know is a major application of telehealth right now. And we were recruiting again across these 3 states. We were looking for these primary care patients. We recruited in a whole bunch of different ways. Our initial sampling goal was equal sample sizes across the medical centers, but we were also looking for data saturation. So we kind of went back and forth between those 2 goals. We initially had lower than expected recruitment of Spanish-speaking patients, and so we boosted that. We were able to administer the surveys, the qualitative interviews in both English and Spanish. And did a variety of different types of coding on this. We ended up with a pretty large sample. We had 65 patients across 3 states and 21 providers. Our primary research questions for this qualitative work were, what was it like to be a patient either trying to use telehealth or successfully using telehealth? What was it like to be a healthcare provider doing this? And what were the effects on patient-provider relationships? That was one of our primary research questions. And then we were very interested in disparities. What were the roles of social determinants of health in terms of broadband access, in terms of education and other social determinants? However, those interviews were so rich and so people were so eager, I think, to share their experiences with us that we ended up learning a lot of other things. A lot of emergent themes came out. We ended up publishing about what it was like to live with chronic disease during the pandemic, teaching and learning how to in the medical schools, paying for healthcare, privacy during video visits, a whole bunch of different areas. So in talking about the qualitative results, I'll pick a couple of these and I'll provide you a list of what we've published so far at the end. So first, patient-provider relationships in the virtual world. We, not surprisingly, heard a lot about barriers, especially when there were any disabilities or other barriers to communicating in English, where providers were saying it was much harder for them to get that information they needed, and they had to try harder, basically. There were complaints about ability to develop that kind of patient-provider rapport that we're all looking for when we go to the doctor, where doctors were saying, I want to be able to see people's faces. Also, we were being told if we already had a strong relationship, then you could continue that by telehealth, but it was much harder to establish that kind of relationship, which I think we all agree that makes a lot of sense. Interestingly, the patients didn't always have a very positive impression of their provider's attention. We had someone complaining because the doctor was taking the video visit from home and their cat walked across the screen, which is something we've all now encountered, but at the time this was very new. the patient really that felt a little disrespected, that this was not professional. And broadly, we had a lot of patients who were not happy that their providers they were seeing their providers in this much more informal setting. And they might have family members in the background. So I think we're accustomed to worrying about whether the patients had the privacy, but the patients were complaining about the doctors as well. On the other hand, we also had patients who told us that they felt like they got better connection with their doctor because they were making eye contact through the video, which is, I think, also interesting. An unexpected, or maybe this was an expected bonus, was providers saying that they really valued being able to see their patients' homes. So they could do things like see their family members, conduct medication reconciliation by showing pill bottles on the screen. They could, we had one clinician who told us that they discovered their patient was a hoarder, which they had not known before because they could see into their home. So unexpected insights into the care of these patients because of that window into their home. I told you that our secondary goal was really looking at the potential disparities. And, you know, at this point, I feel, again, with this audience, I feel like you are very well attuned to the disparities in this country when it comes to information technology. So perhaps these are not going to be that surprising to you, but we definitely found them in our interviews. I'll start with neighborhood and built environment. There are still lots of regions where it is quite difficult to get internet access. We have a lot of phone-dependent folks, people who are getting any internet they've got only through their phone, and they may be paying for that data, so they may be really limiting their internet access, even if they do have it through their phone. We saw a lot of patients telling us that they really relied on their teenage kids to get them set up on the video conference. And we found isolated people who did not have that sort of social support that they really needed. So I think my first quote was that the providers were seeing the gaps in who they were able to reach through high-speed internet. But we also saw the people with fairly severe medical conditions who saw this as a huge bonus that they themselves did not actually have to try to travel to the doctor's office. This was obviously a patient with heart failure. This was the social support that I mentioned. This patient number one here from New York City who says, I live alone and it's very difficult for me to understand technology. This is exactly the sort of person that we would most want to reach through telehealth, and the person who's least likely to be able to benefit from it because we don't have that support for them to get over that initial hurdle. But getting over that initial hurdle did in fact start to become one of the priorities of the different medical centers. And so they developed training materials, they developed procedures where sometimes the patient would first talk with a nurse to get them set up on or a medical assistant to get them set up on the video visit, and then got handed over to the doctor. There were a number of different, I think, really useful support approaches that the different places used. And we did have patients who told us that was really helpful and it got them over that initial hump. But not always. And especially in the early days of the pandemic, the doctors themselves were trying to do all the tech support as well as the medical care, which was not tenable and immediately became apparent this couldn't go on. But this doctor was actually trying to get the patient to download Zoom and set up their account, and ended up doing this as an audio only visit in the end anyway. So I think, you know, this demonstrates that we are seeing those disparities. We are seeing those lack of access in certain populations, but it also did give some reasons for hope, is that there were people, I would say, sort of on the edge who might never have done it if this hadn't happened. But then this happened. This was their only way of getting care. They were able to be given the support to have that first visit, and then they became regular users of it. And so I find that actually pretty hopeful as well. Okay, so the final thing I'm going to say about our qualitative work was that we did not ask the academic clinicians anything about how they were continuing to teach medical school during the pandemic, but it came out in the interviews anyway, and we ended up writing a separate paper about this. It turned out that, medical school teaching doesn't stop just because there's a pandemic. And so they had to figure out how to roll this into their teaching. At the beginning, everybody was just sort of figuring out from the ground up. There was no guidance from the medical school or from the residency programs about how to use telemedicine with learners. And a lot of people told us about either they individually or their medical center developed these teaching methods through trial and error. They were still getting assigned students, and there were weeks where they just didn't really do any teaching because they couldn't figure out how they could integrate them. Once they got up and running, they were able to start integrating medical students and residents into the video visits, and there were unexpected benefits. This one came up a lot, which was that a lot of different teachers, instructors, discovered that what they could do was give the resident the ability to direct the encounter with the patient, and then the preceptor would lurk on the video call. Basically, they turn off their camera and listen only, and then they could have a debrief after that visit, where the preceptor had been able to really listen in and critique, provide constructive criticism in a way that probably was even better than in an in-person visit where you would have seen the doctor, standing there in the corner of the room. Strong desire to take this experience to heart, and there actually are now a number of initiatives to train learners how to use telemedicine and integrate telemedicine into routine medical school and residency training, which I think is great. Okay. So that was sort of a taste of a lot of our qualitative work. We had a really big team. As you can see, I was putting some of the authors down in the corner there. We had a pretty big team, and we had different people taking the lead on different ones of these analyses. I'm now going to turn to our quantitative aims and trying to take some of the hypotheses that we generated during the qualitative work and test them in more quantitative work. So the first one is, we were getting both positive and negative feedback in the qualitative work about the impact of telemedicine on the quality of care. So we thought we would do a quantitative survey with patients and do this in a more rigorous fashion. So we did a quantitative online survey of more than 2,500 users of electronic patient portals. And it turned out, we just did an all-comers type of recruitment. It turned out that 21% of those at that point had at least one telemedicine visit. I will sort of start by saying the limitations, you can probably already tell from this sample, is these were all people who already had an electronic patient portal account, so MyChart or something like that. So we're probably already selecting the somewhat more digitally literate, potentially more affluent group of patients. However, we did get a fair amount of diversity in this group anyway. We confirmed that there were no differences overall in the patient perceived quality of care, but in subgroup analyses, for the subgroups where we had sufficient power, we found some interesting things. I think it's not that surprising that we found that older adults, that's that top line there, were less likely to think that telemedicine communication was high quality. Perhaps not surprising, given the fact that these folks are less likely to be digital natives and also more likely to start having things like hearing problems that might make it more difficult to interact with somebody in a video visit. Unexpected was the men versus women. Men, robustly and statistically significantly thought that communication in telemedicine was worse than communication in person. we're really not sure why. And maybe when we open this up, I'd love to hear people's conversations about this. This persisted even when we, controlled for age and other predictors for things that made more sense. And then, going back to the not surprising, we found that people who were trying to use telemedicine for routine care of their chronic conditions were somewhat less happy with it than people who are using for urgent care. In other words, if you actually had a COVID diagnosis or had some urgent care need that was very circumscribed, people were actually really happy with telemedicine. Whereas those people who were potentially managing their diabetes and going to see the doctor multiple times per year were less happy when they were forced to use telemedicine for that purpose. So this set of results is about their perceptions about communication quality with their physician. This one was their perceptions about the quality of the care they received, and it's very, very similar to the communication quality. They're really strongly correlated here. So older adults, men, and non-urgent care seekers were less happy with telemedicine. Okay, so the big finish is the one that's not quite finished, I have to admit. This is where we were trying to take a look at the objective data about the impact of telemedicine on the quality of care. We focused on three, a couple of measures of quality of care that we thought were likely to be associated with the pandemic. So here's our conceptual model, very simplified, which is that the COVID public health emergency was likely to affect what we call preventable or avoidable emergency department and hospital usage via access to primary care. In other words, if the public health emergency disrupted our access to primary care, then folks who were not able to get primary care were more likely to unexpectedly end up in the emergency room or in the hospital for things that could have been taken care of if they'd been getting routine primary care. Preventable emergency room visits are considered those that are either people going to the emergency room when really primary care would be better positioned to solve their problems. We see this type of emergency room utilization a lot in places where people are underinsured or even uninsured. They will go to the emergency department, as I'm sure people know, to try to seek primary care. So that's one sort of preventable emergency room activity. The other one is what's called ambulatory care sensitive conditions. And that's if you have a chronic condition and it's being managed in primary care, well, then you should not end up in the emergency room. But if you're not getting the primary care management that you need, you might end up in the emergency room. So those are the two types of preventable emergency room visits. Preventable hospital use, people don't usually go into the hospital for primary care, so it's just the ambulatory care sensitive conditions that land people in hospitals. So for this project, we turned to Medicare claims data. We are looking at the comparative effectiveness of telemedicine and in-person primary care for adult patients with chronic conditions during the PHE, that's the public health emergency. We used an event study design, a difference in difference analysis. We were looking at the Medicare fee-for-service patients at those 4 medical centers. We were focused on 5 conditions of interest that were of interest to PCORI as well: congestive heart failure, diabetes, asthma, chronic obstructive pulmonary disease, and hypertension. We ended up measuring the exposure at the primary care practice level, and that's something I'd be happy to discuss a little bit more in the open discussion. Because of the disparities, we were worried that if we divided patients into whether they got telemedicine or not, we would just replicate the disparities, the socioeconomic disparities that we know prevent people from accessing telemedicine. So we thought that we might get less biased results if we measured quality of care at the practice level. In other words, the primary care practices were segmented into whether they really adopted high degree of telehealth particularly during 2020, or whether they didn't. And then we aggregated the patients into the practices. There are strengths and limitations to that approach, and we can discuss later. As I mentioned, our outcomes were avoidable emergency room encounters and preventable hospitalizations. And we also had a measure of continuity of care. Continuity of care is essentially how much of your care you're getting from your routine providers. It's an index that goes from 0 to 1. 0 means every single time you go to the doctor, it's a different doctor. So completely fragmented care. That doesn't happen that much. 1 is every time you go to the doctor, it's always exactly the same doctor. That also doesn't happen that much. But generally, values that are on the higher end of that indicate more care continuity, that you are following up, you've got regular providers and you're following up with them regularly. And we adjusted for a bunch of socio-demographics that we were confident were going to be related to this. We ended up, I realized my chart, my table here doesn't show the number of patients was almost 50,000 patients. What I've got there is the patient quarters. And you can see this is an older population. Obviously, these are all Medicare patients. About a little less than 20% of them were also eligible for Medicaid, suggesting that they're low income. 3/4 are about white. We were hoping for more rural patients than we got. We're hoping that UNC and Florida would have more rural patients, but not quite as many as we'd hoped. Almost, you can see majority of these patients had 4 or more chronic conditions. So these are relatively involved people. And then when we look at the zip code level covariates, about 80 to 85% of them are in neighborhoods where most people have computer plus broadband subscription, meaning that a good 15 to 20% of them are likely don't. And the median income was around 75,000. So when we did our difference in difference analysis, these are preliminary results. We're still doing all of our sensitivity analyses right now and confirming our results here, but I'll just walk through to say that the take-home message here is that the high telemedicine practices do appear to have slightly better continuity of care measures. They seem to be better at getting their patients to be seeing the routine providers on a continuous basis. It's not a big difference, but it was there. It was statistically significant, both globally and across subgroups. But we did not see any significant differences in either avoidable ED admissions or preventable hospital admissions. I think, initially we might look at this and say, oh, telemedicine is just as good as in-person care. But if we think about this in the context of the pandemic, I'm going to say I would interpret this a little bit differently. Take this with a big grain of salt. This is my salt shaker. We are still finishing the sensitivity analyses and the subgroup analyses and hope to have this done by the next month and have a finalized draft, but this is hot off the press. So the reason I'm saying that this is a little bit more of a nuanced interpretation here is that, again, going back to this conceptual model we have, which is that the public health emergency disrupted access to primary care, which we would have expected to see some potential increase in preventable utilization after that. If telemedicine had made up for the disruption, then we actually would have expected the telemedicine practices to perform better on these measures of healthcare quality, and they didn't. They performed pretty much the same. So we're interpreting that at the moment, pending the sensitivity analyses, to mean that both telemedicine and in-person care were similarly impacted by the disruptions of the pandemic, and that telemedicine probably almost certainly was better than nothing, but it didn't fully make up for the disruptions the way we've kind of been hoping that it would. Okay, so the final subgroup analysis here is there any chance that this is exacerbating the existing disparities that we know affect the US healthcare system? Mixed findings here, I'd say. None of the subgroups showed any differences in utilization, so that didn't show up anywhere. The continuity of care improvement we saw was in the higher income patients, not in the lower income ones. It was in the metropolitan areas, not the rural ones, although I'm going to caution that we had some sample size problems with rurality. And it was in the non-dual eligibles, meaning these are people who are eligible for Medicare only and not also eligible for Medicaid, so they were probably the higher income Medicare patients. So that's not great for impact on disparities. On the flip side, we did see a sizable benefit actually in continuity of care for that sicker population. These are the patients who had 4 or more chronic conditions. And we saw actually quite a nice bump in continuity of care for them. So I would consider this somewhat mixed findings, is that it is possible that we are preferentially benefiting those people who already are, at a higher socioeconomic level. But on the other hand, it does look like we might be helping the sicker patients, which is also a good thing. Okay, so I think I can summarize by saying we have seen a permanent change, I think, in the way medical care is delivered in this country. Medicare is still covering telehealth visits. They've extended that to the end of 2024. We don't know how long they'll extend it. We do think that there are some problematic disparities issues here, but there's a little bit of mixed findings as well. We saw, rapid changes, as I mentioned earlier, during the year 2020. I think we probably need to go back and look at, now that things have stabilized, what does telemedicine look like now? Because I think even comparing 2022 data to 2021 data might not be valid, given how much the telemedicine intervention itself changed during that time. But we also found, I think, sort of hopeful signs here that the medical education community adapted relatively rapidly. The primary care providers adapted relatively rapidly, tried to form new relationships, tried to support their patients. And we see, today I'll ask, if anyone on the screen has actually had a telemedicine visit in the last year. It's really become much more seamless. You can often schedule as easily as you do for in-person care. There's often a very seamless workflow to get the patient into telemedicine. So I think that this is probably here to stay, and we still need to work on the broadband access part of it. Lots of limitations here. We're not finished with the analyses. I presented a whole body of work with different methods and different patient samples. So I think we can't really consider these to be validating each other. I'm going to say they're sort of triangulating on the same problem from different angles. Big changes in telehealth delivery, and then the impact of the pandemic itself, particularly on our primary outcomes. There's been other work showing that these measures did change and in unexpected directions during 2020. So that's part of our sensitivity analysis, is to try to make sure that we are robustly accounting for that before we draw any firm conclusions. Great. So take a moment here to plug our next project as we finish this previous PCORI project. I've got a graduate student now who's working on a very cool sort of next step that is unique to the state of Tennessee, which is kind of nice. We have one city in Tennessee, that's Chattanooga, that has created a municipal broadband company, and they run it almost like a utility. They managed to undercut all of the commercial providers, so better quality at lower cost, and they now have just extremely high broadband adoption in the city of Chattanooga. and extremely high service. They're at like 100 megabits per second now. They're just ahead of the rest of the country, let alone the rest of the state. We have access in our department to Tennessee Medicare data as well as Tennessee educational outcomes data. And I know there's folks at Quello who've looked at educational outcomes of the pandemic. So what we're trying to do is use somewhat similar methodology to look at the impact of this high-speed, nearly universal broadband in one region of Tennessee when it's not available elsewhere. So really excited about that. We're just getting launched with that. More to come, I hope, and open to discussing that with the group as well. Do people want to hear the what went wrong slide? I'm going to be giving this to my students later, and so I thought I would just tell them just quickly, like some of the stuff went wrong. So our funder made us rewrite the analysis plan before they'd give us any money. One of our collaborating centers declined to give us the data that they'd promised us. That was very disappointing. Contracting with a multi-site study is always fun. We had 5 IRBs to deal with. This was not federal, so it wasn't a single IRB. It was just 5 different IRBs. We kept losing access to the CMS data. This was a fun one. Somebody accidentally misspecified the recruitment email, and it ended up going to this entire database of tens and tens of thousands of patients, even though we'd only gotten IRB approval to do 1,200. And by the time we noticed it the next morning, we had twice our sample size. So, I mean, we ended up going back to the IRB and explaining this as a protocol deviation, and it was okay in the end, but it was 24 hours of panic. We had a hard time linking the qualitative data to the quantitative data because we don't have standardized names for the practices. My project manager went to graduate school. 2 of my team members had babies and went on parental leave. I changed institutions in the middle of it. So I've been running this as PI under a subcontract to Cornell. So this was all, ended up taking us much longer than we anticipated. I just want people to know that that's the way these things go. Really big team of great people who did fantastic work across 4 different medical centers. And because this was a PCORI study, they strongly encouraged stakeholder engagement. And we had a very large and active stakeholder board who helped us with things like developing readable surveys and making sure that we were using respectful language when we were describing some of these situations and things like that, and pilot testing all of our instruments for us. And I'm happy to share these slides and a whole bunch of publications to share for anybody who might be interested. And with that, I'll just go back to this and open it up for questions about or comments about people who might be doing similar work or suggestions that you might have for what we should be doing next, particularly with our ongoing analyses.
Thank you very much, Jessica. So we'll go ahead.